good morning.
Good morning, Raquel.
Hi, let's do that one more time with a little more, like, as if we're pretending that we're, like, awake and live and feeling good, happy to be here. Okay, here we go. Good morning.
Good morning.
Let's see here. As Annie said, I work in Berkeley. I'm a psychologist. I've been totally obsessed with this topic since 2002. And I can tell you honestly that for the first 15 years, people thought I was totally freaking nuts for talking about ketamine and its potential therapeutic properties. And then in the last 2 years, people got really interested in what I'm saying. So that was kind of weird. But anyway, here we are. I'm a psychologist, so I work in collaboration with a team of medical professionals who actually prescribe and administer ketamine to our patients. It's not legal for me as a psychologist to administer ketamine myself, and so I wanted to be clear about that. And also, I'm the founder of Kriya Institute, and we'll talk about that later. Yeah, snaps for Kriya, yeah, right on. Mike Margoli's in the back, yeah, okay. So let's start at the beginning. Here's the thing. Ketamine is a medicine that was originally developed, invented, specifically to be a surgical anesthetic for humans. It's actually a derivative of PCP, phencyclidine or angel dust, which is also a very excellent anesthetic. But the problem is that PCP, as you may have heard, is highly psychologically unpredictable or variable. And sometimes people have beautiful experience with PCP, and sometimes people have really terrifying experiences with PCP. So the unpredictability of that substance makes it not good for a therapeutic application and not ideal for anesthesia either. So anyway, in the 1960s, some scientists set out to develop other medicines that have properties like PCP, but that were more stable and more psychologically tolerable. And that's how we came to have ketamine. By the way, people often refer to ketamine as a surgical anesthetic, like to give it legitimacy, like somehow that sounds more serious and more valuable than if it sounds medical. But I want to be really clear that we're not using it as a surgical anesthetic in my work. Rather, we're using it as a glutamate modulator. We're using it as a medicine that alters the glutamate pathway in your brain. And so we'll talk more about that in a moment. But anyway, now the correct categorization, the correct way of referring to this is as a glutamate modulator. So anyway, here's the basics. Ketamine was developed as a surgical anesthetic. It turns out that it has very rapid-acting antidepressant effects. And you may have heard, you may know that it's highly psychedelic. It causes people to report that they believe themselves to be in the presence of God. And how it's doing that, I don't know. Nobody knows. Don't ask me because I don't know. But that's the part that interests me. What interests me is the question, the relationship between mood modulation and visionary experience. Is there a relationship there, and exactly how does that work? So that's what I've been trying to study for 17 years. Anyway, if you understand this slide, this one slide, this is the overview of my whole talk. So if you got this, you're good. You can relax. Everything else is just going to be an elaboration of details on this one slide. This is it. This is the main thing here. Okay. Annie, how much time do I have altogether? You want me to go short or?
Until 11, and I'll give you a 5 minute.
Okay, great. And I want to save some time for questions, so I'll adjust accordingly. Fantastic.
I'll give you a 10 minute.
I'll just keep looking at you, and you know, or you can do. Okay. So anyway, ketamine. Let's go back to the ketamine. Ketamine is one of the things that's interesting about it is that it's totally synthetic. It's made in a lab. And there are no natural analogs. There's nothing on Earth or in the universe that we found to date that hits the same pore or the same hole on the receptor in your brain that ketamine hits. There is no natural analog. And so this raises a really interesting question that I'd like us to contemplate for a moment, which is, how did you get a pore there? How did you get a receptor in your brain How did you get a lock that basically has no key? That for thousands of years and tens of thousands of years and millions of years of vertebrate and mammalian development, we didn't come up with a lock to open that key until the 1960s. I mean, that's kind of existential. So I'll let you just sort of sit with that. I don't know the answer to that either. I just thought I'd throw it out there. Anyway, ketamine is a little teeny tiny molecule. You can see some pictures of it in a couple of different perspectives on the screen. It's easy to get into the body. It's easy to get into the brain. A little teeny tiny molecule. So I'm going to skip ahead here. I want to talk about my work with patients. So we see a couple of different things in our practice. We see people who have refractory depression, meaning people who are really severely depressed and who don't respond much to other conventional treatments. So we see a lot of depressed people. And then we sometimes get some psychonauts coming through, people who are interested in exploring their own mind. And I want to make sure that we spend some time talking about the legality and the ethics of that later in this talk, because that's a slippery area. But in any case, with respect to treating depression, which is really my specialty, there's a lot of confusion and a lot of contradiction, a lot of disagreement in the field about the best way to use this tool. And so what you see in the literature, everybody's contradicting each other. So let me see if I can sort some of that out for you. I want to describe a couple of different ways that we use ketamine therapeutically. And so in listening, I'm going to present 3 different models for working with ketamine, is what I'm going to do. And in listening to that, I'd like you to pay attention to the fact that there's a couple of variables. There's a couple of things that we can change. By the way, can I have my water? Since you're right there. Oh, thank God. Okay, so here are the things that we can vary or alter in ketamine treatment for depression. So one of the places where there's disagreement is what's the best way to get the ketamine into the patient's body? Should they sniff it? Should we inject it? Do we have to put them on an IV drip? Et cetera and so forth. Can they swallow it? This is a question that we're thinking about. How much ketamine do you give at any one time? What's the appropriate dose for this? Do you want to give sub-psychedelic, like a little bit? Do you want to give psychedelic experience? Do you want to blow the person into full-blown paralytic anesthesia? What are you trying to do here? So there's a lot of disagreement about this. How often should we be providing this treatment? Well, that of course depends on the dose. But how often are we doing this? That's a question. Setting. What is the appropriate setting for this kind of experience? It turns out that setting is one of the most important variables in successful ketamine treatment, but one that we don't talk about enough. Setting is critical for this kind of medicine. By the way, hey, other ketamine provider. Let's see, the last question, the last variable, the last thing that we're discussing and disagreeing about is something that I call clinical presence. That means the person who is providing the ketamine, how do they understand their role? What is it that they think they're supposed to be doing with you as the client who's taking ketamine? And there's disagreement about this. Let me start with that one. I want to talk about clinical presence for a moment, because I want to make sure that you understand what to ask for if you are looking for ketamine treatment. So some providers put an emphasis on medical monitoring, and usually that involves equipment and things that beep, and the emphasis is on keeping the patient physically safe. And usually when someone is doing medical monitoring on a ketamine patient, sorry?
I would just say keeping you alive is very important.
Right, keeping you alive. Yeah, I'm all for that.
Definitely.
You're right on.
Oh, yeah.
I mean, well, save that for a question. We're going to come back to that. I haven't lost anybody, by the way, so just...
Yay.
Okay, so... Okay, I must be doing something right. Okay. But the thing about medical monitoring is that in a medical monitoring perspective, usually the medical monitor is not paying much attention to the patient's internal psychological experience. Usually they're not talking to you about your visions. They don't want to hear that. If you start talking about God, that makes them nervous. they're not real concerned about what you're seeing or what's happening inside of you while you're receiving the medicine, typically. So that's what I mean. Okay, now sitting is something else. Sitting is kind of how people are taught to be with clients who are having psychedelic experience. So that's what I mean when I say sitting. It means that you're functioning as a guide. You're providing loving presence. You are following the patient so that the client is describing might be describing what they're seeing, and you might take notes, and you are, as the guide, you're trying not to be too intrusive. You're trying to kind of hang back and just follow the patient's experience. And I want to make a distinction that this is a totally different thing than ketamine-facilitated psychotherapy. Psychotherapy occurs when you're working with a therapist who has the training and the technique and the experience, and also the relationship with you, where they have a sense of your internal emotional landscape, and where they have permission to initiate exploration into difficult topics, and they know how to guide you there and how to get you in and how to get you out. In other words, you're helping the patient to explore their psyche in a more active way. As I said, this can only occur, this only meets my criteria if it occurs within the context of an ongoing therapeutic relationship. And this is the essential part. When you're working in this way, the ketamine is only a tiny portion of the treatment plan. You're doing a bunch of other stuff with that provider that might include conventional meds, lifestyle intervention, talk therapy, etc. So it's not just about the ketamine, and that's an important distinction between a psychedelic guide and a ketamine therapist. So I just want you to be aware of that. People say, why can't I just have my friend sit for me? Okay, well, that's better than doing it alone, so yay that. But the thing is if you had a toothache, would you ask your friend to come over and give you a root canal? I mean, I wouldn't, but okay. If you had pain in your abdomen, would you ask your friend to come over, watch a video on YouTube, and then give you an appendectomy? I mean, I'll just let you think about that. And so why is it okay to have your friend come over and do this thing with you psychologically when they may not have had the optimal amount of training to do that? It's my opinion. Anyway, okay, sorry, I'm going off. Let me now, what I'd like to do next is I'd like to present 3 different paradigms of ketamine treatment so that you can understand what you're reading and make sense of what's happening in the news and in the literature. So the kind of ketamine treatment that you read about the most is something called the NIMH protocol, National Institute of Mental Health. Excuse me for 1 second. Okay, so a couple of years ago, the National Institute of Mental Health and also the American Psychiatric Association issued guidelines on the use of ketamine to treat depression using this particular protocol. And the protocol is that you give the patient 0.5 milligrams per kilogram, so it's based on your weight, of ketamine in an infusion bag in an infusion center for the treatment of depression. It's called the NIMH protocol, and so there it is for you. The patients vary tremendously in their experience of this, but it's not uncommon for people to say that it kind of feels like drinking 2 glasses of wine on an empty stomach. It makes people feel a little bit nauseous, a little bit sleepy, not too bad, but they absolutely know who they are and where they are at all times. They can open their eyes and talk to you in this particular way. And the reason that I bring this up is because more than 90% of the published literature is using this protocol, this exact one, not psychedelic experience. The other thing that I want to say about this, here's the thing. In our practice, we certainly send people for this kind of treatment when they're medically complicated or fragile in a way that they would benefit from low-dose infusion. For sure, we do this. We do send people for this. We used to do it ourselves, we don't do it anymore. But here's the thing that I don't like about this model is that it forces the patient into a passive role. The patient isn't doing anything to work towards their own betterment, except to show up for the appointment and be infused. And so in this model, the medicine is doing 100% of the work, and the patient is contributing basically nothing to their own betterment. And I think that's problematic for people who have a psychospiritual problem. I want the patients to be empowered to help themselves, and I don't see that in this model. Oh, okay, now we come to this. So you may know that in March. Oh, yeah. Yeah, right. I'm right there with you. In March, Johnson & Johnson, they were unable to make a ketamine derivative that does the magic thing that ketamine does. But they wanted to make a product that they could patent. And so what they did instead is they filtered it. They took ketamine, they ran it through a filter, they patented that process, and they made S-ketamine.
That's all they had to do?
I love you guys. Okay, right on. It sounds like you know what this is. And so the deal is that when you feel bad, you go to the doctor's office for a bump of ketamine. They give you nasal spray. And then that's supposed to, I'm not totally sure. Okay, anyway. Okay, so the good news is that this is now FDA approved. And so that speaks to the safety and efficacy of working with ketamine for depression. Ready for the bad news? Here's the bad news. 84 milligrams of ketamine, $850 per dose. The way that I do it, $1.59. If you are holding a bottle of water in your hand, anybody else have a bottle of water? Yeah, I see some water. Okay, you paid more for your water than you would pay for ketamine treatment with us. I just want you to know. This is for the medical supplies, not the therapist time, but you get the idea. This is just nuts. Okay. Anyway, the point I wanted to make here is that in the S-ketamine model, or the Spravato, then in the nasal model, it's the same issue, right? Where the 100% of the beneficial action is attributed to the medicine, and 0% is attributed to the patient and what they can do to help themselves. And I think that's problematic. Oh, that's not supposed to be in there. Sorry. No, don't look at that. Okay, here we go. Anyway, okay, let me move on here in the interest of time. Let's talk about a different way of working with ketamine. Different paradigm. Same medicine, different approach. Same medicine, different philosophy. Okay? So a different way of using the same tool is to do ketamine-facilitated psychotherapy, where the emphasis is on the therapy, and the ketamine is being used as a lubricant for the psychotherapy, the talking process. So this is the exact same model that they're using at MAPS for their MDMA research. And so here you can see a little bit about it. So the idea is that the patient is in ongoing talk therapy, and that they're in a therapeutic relationship where love and trust is starting to build, and there's a relationship and a connection that's starting. And that inside of that sometimes the therapist or the provider offers ketamine to deepen the therapy process, specifically to help the patient to talk about material that is too shameful or too painful to get to otherwise, to lubricate the therapy process. And this is meant to be pleasant. Many patients find it relaxing. They often enjoy it. People consistently report that it's easier to talk when the ketamine is dosed correctly. And so what's interesting to me about this is that when we work with ketamine, I do this a lot, and what's interesting to me about this is that in this model, that each person in the room is each contributing 50% of the effort. So the patient is working really hard on their own behalf, and I'm working pretty darn hard too, right, Julie? We're working hard. Yeah, okay. To help alleviate their suffering and move them toward wellness. So I like this type of model much better for personal work. Oh, I want to just make a side note here. I want to make a side note about something called pseudotherapy. So pseudotherapy is where somebody who isn't trained and doesn't have a lot of technical skill tries to give therapy or tries to engage and talk with someone who's under the influence of a psychedelic like ketamine, but where they don't necessarily have the skill set to be able to manage all the difficult things that can come up. And this is a real dilemma. People who are in an altered state, as you surely know, are very vulnerable. And I wonder if there's the potential to do harm by doing this if you don't have an adequate skill set. So I just wanted to call attention to that as a concern that I have. Anyway, okay, now let's keep going. I said there were 3 paradigms, so here we get to the third one. So, same medicine, ketamine, different tool. Same medicine, different dosing strategy. Same medicine, different values. So again, a different way of working with ketamine is psychedelic ketamine journeys, where as a provider, we are inducing psychedelic and mystical experiences on purpose. We're not trying to avoid them, we're actually trying to launch the person right into that because we believe that the visions are valuable and potentially meaningful and potentially healing. So here's a picture. Let me show you a bit more. Okay, so this is actually what it looks like, the other one. Yeah, okay. Agreement with the audience, got it. And here we'll just, in case you want to see another picture. Oh yeah, okay, people are resonating. Okay, right on. So here's how we do it. And I want to start by saying that doing this kind of work therapeutically requires very careful and technical preparation so that people are spiritually and psychologically safe when they get up into the ketamine space like that. This is not something that we do casually. So we typically do this by injection, and I'm so glad that there was the talk this morning about the dream stuff, because that's such a nice connection to what I'm going to talk about. People report having, their body is quieted, and their mind is freed up to have colorful, dream-like visions during the 1 hour of active ketamine medicine. And so, while the patient is having this kind of experience, as the clinical team, the providers, we don't do that much. We are mostly doing medical monitoring and also providing some loving presence. But the real work happens after the patient comes out of the ketamine experience. And then we work with them to find the meaning, construct the meaning, and construct or identify the message in the medicine. And usually the medicine tells the patient what they can do, or their inner knowingness tells the patient what they can do differently in their daily lives to move themselves toward wellness. And I want to just pause right there because it's that actionable step, that thing that the patient needs to do differently, or is invited to do differently in their lives on a daily basis. That's what makes this therapeutic and distinguishes it from recreational exploration. It's the actionable step in figuring out how to implement it and supporting the patient to actually do the thing. That's where we see the therapeutic benefit. So anyway, this is totally legal, by the way. It's totally legal when done in an appropriate environment with an appropriate medical provider. And it raises a really interesting question, which is something that we can study. What is the value of psychedelic experience? Is it an annoying distraction? Is it extremely beneficial? Is it essential to the mood modulating and life-changing effects of ketamine? We're trying to figure that out. That's the focus of my work. I'm going to guess that if you're in this room, you probably are open to the possibility that the visions are valuable. And so, anyway, but I often have to spend a lot of time explaining this to physicians who just totally don't get what I'm trying to say. You get it. Okay, right on. I'll put this on the web in the interest of time. I'm gonna pass over this. Well, I want to make sure you have time for some questions. This is a longer talk. I'm so sorry. I do want to just briefly touch on another possibility, which is the question of solo work, specifically solo work when the patient is prescribed ketamine lozenges to take home, and where they're using them under the doctor's supervision, but using it by themselves. And there's a lot of risk here, and there's a lot of question about whether this is, how useful this is. So we're just actively studying this. A lot of researchers are looking at this phenomenon. We want people to be physically safe. We want them to be psychologically safe. There's some doubt as to whether it's as effective as doing it in the presence of a therapist. Here's the thing. The truth is that ketamine and many of these sacred medicines, they're relational medicines. Ketamine is a relational medicine. And what I mean by that is that when you put ketamine in, it helps people open up physically and psychologically to a window of relational relearning, to the possibility of setting a new template or doing some very deep work on your expectations about relationships and your relationships with other people and your relationships with yourself. And so the question is can you do that work if there isn't somebody else there to work to be a relational object? So this is the thing that we're struggling with, and I'll get back to you next year with more data. Anyway, we've covered a lot of material really quickly, but basically just to recap, I proposed one model for working with ketamine where the emphasis is on the biochemical or pharmaceutical effects of the medicine. Proposed a different model where the emphasis is on the psychotherapy process, on talking. And I proposed yet another model where the emphasis is on having sacred visions and where there's basically no talking because the patient is too high to talk. And so we do all of this in my practice. And so, as you can imagine, obviously the question, you can imagine the question that I get the most. The question that I get the most in my practice, in my work, is can I have some free drugs? And the answer is no, I can't help you with that. Okay, but the second question that I get the second most is which of these models works the best? As a patient, what kind of services should I get for my severe depression or for my loved one? As a provider, what should I be offering to my patients? So I'm going to tell you. Are you ready? Okay. The answer is that different things work for different people, and I'm all about individualized and customized treatment. And so for some folks, low-dose infusion is the way to go. And so we make that available, or we help people find that resource if that's what's clinically indicated. And other people are tied up in knots, and you can see it. And what they really need is some ketamine-facilitated psychotherapy. They need to talk it out. And so we use the ketamine to help in that process. And other folks, a very small percentage of folks, about 1 in 6 in my clinical practice, a very small number of folks, are actually a good candidate for a full-blown, to the Pluto and back psychedelic experience. And it would be wildly inappropriate for other people. And so this is really the task of a good ketamine consultation or a ketamine specialist, is to know the difference, what to do when. I don't believe in a one-size-fits-all approach. I think that's crazy. I think that we should do what each person needs, the person who's sitting in front of me. How can I help? How can I be of service? What can I recommend right now that I think is going to be helpful and appropriate? And so that's really the work. Oh, it says connection lost. But I feel connected to the divine. It can't be lost. I'm going to skip ahead to some resources for you. I know, I'm sorry. So I want to make sure we have a few minutes for questions. Okay, great. I'm getting the signal over here. Wrap it up, Raquel. Okay. But I wanted to say that we offer clinical services in my practice, and we also offer a lot of different kinds of training, including experiential training. Ask me later what that means. And so I have an introductory lecture that's 2 hours long that covers some of this material but in more depth. And then I do some mentorship, and then I run Kriya Conference. So Kriya Conference is an annual event that takes place in November. You can find more information about it on my website. And that's the gathering place for all the senior ketamine clinicians and researchers. So you can look on the website for that. Oh, I think I just mentioned this. Okay, Kriya Conference. It'll be November 9th to 10th this year. We're in our 5th year. And finally, let me leave you with some resources. So if I've piqued your interest in this topic and you want to learn more about it or talk about it some more, my website is a great place to start. There's some books there on this topic. There's a bunch of articles. There's some really cool videos. Check out the one of Hamilton Norris from Hamilton's Pharmacopoeia. He spent the weekend with me, and so that video is up. It was a crazy weekend. Ask me later for that story. I have some of my favorite music up for ketamine journeys. Really important, I maintain a list of all of the local providers who are providing therapeutic ketamine services. So if you're looking for someone to provide ketamine treatment, hop on my website and check out the list. By the way, I want to give a shout out to Sage Integrative Health and Julie Megler. So Julie and her colleague run a integrative health clinic, including psychotherapy and psychiatry services here in Berkeley, and they're fabulous. So make sure you check them out. And if you want to hear me in other places, or you want to get news about ketamine, you can join my mailing list. Also, there's a link to contact me that goes right to my inbox, so I see everything. I'm pretty good about writing back. So let me stop there, and do we have time for a couple quick questions? Okay, and let me just say thank you so much for coming today and for hearing this talk. It's a pleasure. So what I'd like to do is I'd like to take a couple of quick questions about ketamine treatment in general. If you have a specific case or you need consultation on a specific person, I'd like you to contact me to make an appointment. I'm not able to get into individual cases in this setting. That's not legal.
Not asking about cases, but my name is Angela. We have a ketamine-assisted therapy clinic in Seattle where we're doing integrative healthcare. The big question I have for you is how the hell do we get insurance to cover this therapy? I know that with as ketamine that there's a push towards doing that, but how are we going to do that? Is there a way we can coordinate together? We can have some pressure. I really want to know how to have this therapy under insurance.
Yeah, that's a great question. Are you working with Nate Schmidt, by the way? Yes, right on. Yeah, they're great. Okay, I know those guys. So I've been trying to get people to get together to coordinate their data and to standardize their data collection process for at least 5 or 6 years. And we talk about this every year at CREA conference. Phil Wolfson actually has a data collection program where he's been trying to do this, but his forms are so freaking long that the providers don't want to do them. So what we need to do is we need to form a work group. We need to work together to create. Yeah, you're in. Okay. You heard her say that. We're holding her to that. We need a way of tracking patient assessment and patient outcomes. We need to collate or combine our data from multiple practices, and then we need to evaluate, and then we need to submit that ultimately to the FDA. She's asking, how do we get insurance to pay for ketamine treatment using generic ketamine, not as ketamine? And so I'm totally there. I'm totally with you. I'm happy to help you with the mailing list. We've got 1,000 providers on the list. Here's the thing. The problem is that it's not. The problem from a capitalistic perspective is that it's not financially rewarding enough to put together the trials that are needed to win FDA approval for a generic product. There isn't any economic incentive. And so if we're going to do this, we have to do this using our own heart and our own desire and our own resources and our own feeling that this is the right thing to do, but we're not going to make any money off it. And I'm okay with that, but we gotta find the other folks who are okay with that also. Yeah, thank you. Other questions? I'll take one right here, and then we'll go back there. Go ahead.
Okay, I'll try to be concise. So I received ketamine infusions at the medical monitoring model. Thank you. I received the 6 ketamine IV infusions through the medical monitoring model that you described, and I've been researching clinics across the country to recommend to friends. And I've noticed that all of these clinics describe it as the dissociation effect, which seems like a euphemism to me. And on all the websites, they say things, if you click on what is it like, they say patients describe as unusual, odd, interesting, and that was all that was presented, and that was all that was presented to me when I went about what the dissociative experience would be, and I had to sign off on that, and I already knew I was well informed about what it would be like, but this seems to me like an issue of informed consent, like it's not ethical to me to describe it that way, and not, my experience was highly psychedelic, and it was not interesting or odd, it was extremely profound, and it's very upsetting to me that I'm seeing it described in this way, and this euphemistic dissociative effect.
Yeah, let me comment on that.
Yeah.
Thank you for sharing this, so interesting. So here's the thing. The thing is, I think what you're speaking to is that the medical model, traditional Western medicine, for the most part, has a fundamental bias against psychospiritual experience. And so they apparently think it's a bad thing if you have a shift in your perspective in your relationship with yourself, or if you feel the divine energy coming through you and you find your place in the universe and you believe that you're in the presence of God. Apparently that's a bad thing. Now, I've never really understood that. And particularly when you have a patient who's actively suicidal and they understand that, they spontaneously articulate that they are blessed by the universe and everything is as it needs to be in that moment. I'm not sure why we are turning away from that. But this fundamental bias that you see played out on these websites and in what doctors say, the thing is that it's preventing us from asking really important questions about the use of sacred medicines. And so, from my perspective, how can you study a phenomenon if you refuse to acknowledge that it exists? You know? And so first we have to talk about the fact that people have visions and non-ordinary experiences with various sacred medicines, including ketamine, not limited to ketamine, other medicines too. But once we acknowledge that that's part of the experience, we all know that, but once we get mainstream medicine to acknowledge that people are having those kinds of experiences, then we can start to assess how valuable they are, how long-lasting they are, when is it harmful, when is it risky, who's a good candidate, etc. I wanted to say one other thing, and I think I'll wrap up on this note, which is that there's something also wrong with our measurement tools, the way that we measure psychiatric outcomes, in a lot of ways. Yeah, I'm seeing some nods over here. And specifically, when you put someone in a study and you give them any new medicine, or ketamine, or S-ketamine, or whatever, typically you assess their symptoms, you assess their improvement usually on the same day, or the day after, or 3 days post-treatment, maybe 21 days if you're lucky. But what about the part where people have life-changing experience? Me personally, I first encountered ketamine 17 years ago, in 2002, and that's how I came to be interested in this topic. And I'll tell you the truth, I'm still affected by the vision that I had on that day, 17 years ago, that was life-changing for me. Yeah, holla, people are like, yeah, me too, okay. And the problem is that we don't have longitudinal studies. I mean, we can design them, just nobody seems interested in utilizing them, to study what happens to people when they have visions that are deeply profound and meaningful and that potentially will alter the course of their lives. What do you do with that data? So anyway, I'm going to leave it there. Listen, if you have any further questions, okay, I'll take one more. But before I forget, I want to say that you're more than welcome to reach out to me through my website, and I'll be around for a bit. And I guess it sounds like we're taking one more question. Okay, please.
All right. So Raquel, on behalf of everyone, I'm sure we wish you could go longer because you're amazing. And you know, when you spoke of the MAPS, what they're doing to activate the MDMA trials, the conversation that I was hearing underneath that was the potential of supporting people of color with these trials and kind of introducing to populations who normally don't have access to psychedelic medicine, the potential of that. And I'm curious if you know of any potentials around supporting people of color trials for?
Yes, well, sort of. Let me try my best with that. Thank you for the question. So glad you asked. So, yeah, absolutely. This is a huge problem. The question, as I hear it, is how do we make ketamine treatment more accessible, specifically more financially accessible to people from underserved and underseen communities? That would include people of color. Also in my heart is people who are disabled and people who are identified as queer, et cetera, and so forth. How do we do that? And so there are a couple things that I want to say. First of all, patients need to request and providers need to provide generic racemic ketamine at $1.59 a dose. Okay? Forget this ketamine thing. Number two, the cheapest way to provide therapeutic ketamine is by injection. And I'm always a little hesitant to say that because this is not something that you can do safely outside of a medically safe and legal context. But in a doctor's office, the cheapest way to get ketamine is 25 cents for the sterile syringe. So now we're like at $1.74 or something, is that right? For supplies. So this is much less expensive than any of the other routes. And so we need to be using this more. We're underutilizing that, number two. Number three, I'm super interested in the use of ketamine in groups. So basically what we're doing is we're doing an ayahuasca ceremony with no ayahuasca. We put ketamine in instead. And what's good about this is that I can see, and my team and I can see 6 patients at a time. And so that means the cost is 1/6 for the patient. And I'll tell you honestly that our income goes up and the cost of services goes down for the patient. So this is a good thing. This is a win-win. So that's another thing we can do. We need to take this idea from over on this side of the room. We need to get FDA coverage, which would lead to medical insurance coverage of ketamine treatment for the specific clinical indications. And finally, the last thing that's happening is that me and many of my other colleagues in the community are creating ketamine patient assistance funds to subsidize the cost of ketamine, during this transitional time, as we try to get FDA coverage, because really what I want to do is I want to help the most people, and we definitely need to overcome the hurdles so that we can make this more financially accessible.